Thank you very much. Sorry that I was late. I think in moving forward, we need to recognize that we really do not have much of a health care system in this country. We have a really, really good sick care system, the best in the world probably. And I hope that in moving forward that we are focused a bit more on, a whole lot more on health care. Maybe if we had a better health care system, we wouldn't need to have such a big sick care system. One of the problems that we have in rural areas, and I guess in some of our inner cities too, is that the government now controls the health care for almost 50% of our population. All of our military, all of our veterans, S-chip children, Medicare and Medicaid. And by design, the government intends to pay less than the cost of health care. Obviously, you can't do this or you can't stay in business, so there's a lot of cost shifting going on. How are you dealing with this problem in rural areas where frequently large percentages of your patients, I have some rural areas in my district and I know that some of their nursing homes are 90-odd% all Medicaid. Tough to run an institution when the person who's paying the bill intends to pay less than the full cost of health care. How are you dealing with this?
Well, at a large academic medical center, this is an acute problem because we do not refuse care to anyone because of ability to pay. We our trauma patients very frequently are Medicaid patients. Now, we are lucky to live in a part of Pennsylvania that also has a pretty good payer mix in other parts of the population, and it's clearly cost shifting that people who have insurance are paying enough to care for the people who don't cover their expenses with Medicaid.
You have to do this or you're out of business. Yes.
I think it is really becoming an issue. I deal with 65% Medicare patients, and realistically, it's coming to a point where I cannot any longer be a private physician running my own business. After 30 years of doing this, 30 years of being a very good, efficient, busy physician, I have not been able to give my employees a raise for 5 years. I've not funded my pension profit sharing plan. I'm looking at other options for my practice at this point. I will probably become an employed physician. We will probably lose another small business. And this is a time where I should be doing well, not suffering. And that's a personal story, but that's the way I think most people are struggling with it, not very well, hoping they get enough of the private insurance people who pay a little better that they can keep going, or looking for other people to pay those bills. Studies have shown the average primary care physician loses $80-some thousand a year.
Dr. Heim?
There are a few things that I think we can look to for models. One is in North Carolina, we have the North Carolina Community Care, which actually is built around Medicaid patients right now. And as you said, you lose money on your Medicaid patients. And so simply filling up your practice usually with Medicaid, like any small business knows that volume doesn't work when each time you lose more money. So, but in the North Carolina, the community care, what they have done is it's a patient-centered medical home model. And the state has paid the primary care physicians an additional payment per Medicaid payment in order to coordinate the care specifically across certain disease states. What that has done is it's increased the payment for the primary care physician to a point that they can afford to not only see these patients but do the coordination of care, and in fact to save the state over $250 billion in the length of the program. The other thing that I agree, I think what we're seeing is a change in primary care practices. They're starting to do more, which is not what we want, because the system has driven people to simply do more things rather than looking at health outcomes. And we've also seen that there are a lot of our members who are now selling out their practices and starting to work for hospital systems, or they're starting to leave and go into other practices.
And I would like to point out that I think not only primary care physicians practice preventive care, and much of what I do is preventive care. The patient with the symptomatic carotid stenosis who is at risk of stroke, there's a very effective surgical intervention to prevent a stroke and all of the costs that go with that. The patient with the unruptured intracranial aneurysm who is at risk of a devastating hemorrhage, if that aneurysm is fixed before the hemorrhage occurs, that saves an immense amount of cost in the system. And as I mentioned briefly in my testimony, I think there are neurosurgical procedures just around the corner that would offer a minimally invasive and effective treatment for things like addiction, and that means addiction to tobacco and alcohol, and et cetera, and obesity. And that would be a neurosurgical example of very effective preventive care that could save immense amounts of money. So when we talk about prevention, let's be clear that many of us practice preventive medicine even if we're surgical specialists.
I was going to comment that colonoscopy and early removal of polyps has a great impact on lowering colon cancer mortality, which has already seen progress since that's become more common. Similarly, one of the differences that the United States has led the world in is frequency of mammograms. Instead of diagnosing a breast cancer at stage 3, where you're getting it at stage 1. As far as programs that have been authorized by Congress, the AHEC program in our state has also been very effective in helping with some of these things and making access good.